Our second speaker is Professor Shanton Chang. Shanton is Associate Dean at the Faculty of Engineering and Information Technology at University of Melbourne. He's a mixed methods researcher and co-lead of the Digital Access and Equity Program at the Melbourne Social Equity Institute. He's interested in digital inclusion strategies, especially in the development of digital interventions. Today, Shanton will be talking to us about a matrix for asking the right questions of end users when designing a digital health intervention, and how he's used this to address equity in bowel cancer screening in communities in called communities. So thank you for being here, Shanton.
Thank you, everyone. And it's such an honor to be invited to be part of this session. So I look forward to a conversation with all of you at the end as well. So I'm going to start sharing my screen. Give me 1 second. Here we go. All right. Can you all see it now?
Yes, we can see it.
Fantastic. Thank you, Wendy.
Although Shanton, we don't see the slide show.
Oh, okay. Let me
We just
just
see the
sort it out. And isn't it good to know that I'm from the School of Computing and Information Systems? Give me a second and I'll try again.
Okay.
Is that better?
Yes, that's perfect.
Fantastic. Okay. So thank you very much again. And as you know, health background, but as Wendy had indicated, the CDTH is a collaboration between the medical school and ourselves. So I come at it from quite a different perspective in looking at computing, technology, and information systems. So my presentation is going to be quite different from that point of view. All right. I want to begin again by acknowledging the Wurundjeri people who are the traditional owners of the land on which the main campus of the University of Melbourne is based on. And I think this is important, not just a tradition that we do in terms of acknowledging the traditional owners but also to recognize that it is a living culture and that there are huge impacts on their health. And also in looking at the digital health, that it is a sector that often is misunderstood. And so it's very important that we continue to work hard in this space and to work collaboratively with them, with the community, and with the various communities. And I hope that my presentation will show some of that as well. And so I want to pay my respects to the elders past, present, and emerging. And also anyone who is watching this who are part of the First Nations people. So to move on very quickly, my presentation is really talking about information equity. And to start off, I want to talk and share this slide around digital access. A lot of people are very conscious of the idea that if we are going to do digital health well, we have to make sure that digital access is right up there. And so I put up this kind of definition of what digital access is. And it's this idea that if we are looking at digital access, it's not just about whether or not people have access to technology, but really we should be really looking at digital inclusion, which goes beyond access, right? So that if we're not just looking at affordable and we're not just looking at broadband, we're not just looking at whether they have the devices, whether they have access to digital literacy and training, or that they have quality technical support. Those are things that gets them there to the platforms, to the websites, for example. That's access. But if we're looking at digital inclusion, And we're really interested in not just the access, but also the use of information and communication technologies. So access is one thing, but inclusion is another thing. And this is why it's so important. When we look at the world of social media, for example, and where a lot of people are getting their health information, I always love sharing this slide about what people are actually doing online. And you get a sense here that we do spend a lot of time online, and in terms of public health communication and all that, it's really important to get our heads around this. Not to say that you all have to be doing all of these things, but the point of this is to show you the diversity of the way that people engage with online information. But beyond that, while we are familiar with a lot of the platforms on the left side of this slide, on the right side is similarly what's happening, for example, in China. And you start to see all these other platforms that are also being used in a different language, for example. And migrants who come to Australia, for example, or to New Zealand, do not stop using these platforms. They continue to use these platforms. And you start to see that even access sometimes can be an issue if we put all our information on particular platforms that we are familiar with without being aware of all these other platforms that our target audience are using. So this is why access is an important question to still have in our minds, but more importantly, to look at inclusion as well. And what does that mean? If we're looking at digital equity and digital inclusion, we're really saying that we need to move beyond access to go into inclusion to ensure that there's some sort of digital equity. And so here's the definition of digital equity. It looks at individuals and communities having the capacity and the ability to engage because it allows for civic and cultural participation, employment, lifelong learning, and access to essential services. So what does that mean? So of course, we talk about digital access and inclusion, but it's also about the understandability of the online content, the digital content, that it has to be inclusive of particular groups in terms of how they use that information. And the reduction of choice or the inability to exercise choice online can be an element of lack of equity, if you know what I mean. Because just because you got there doesn't mean that you have any idea how to navigate the website, for example. That's the best example I can give. And it can be biased towards a particular user experience design. So this bias means that, if a lot of people who design digital interventions in health tend to say that they do engage with a co-creation process, they do think about this idea that they have to engage with the people who are going to be the users, but who they get into the co-design is a question that we constantly ask people to really think about. It has to be quite representative. It has to look at different socioeconomic backgrounds. It has to look at language groups, multicultural, multi-faith groups. And of course, one of the key things there is to ensure that we are not just talking to people who have high digital literacy. And that's the challenge in so much of the work that we're doing in the public health and digital health communication space. So, and of course, the last one is to recognize that our target audience tend to use quite diverse social media and online platforms, and that can sometimes be a challenge. Let me just keep going here. Okay. So when we talk about digital equity, we then have to look also then, as I said, it's not just about getting to the website, but whether the information on the website or the digital intervention is accessible and understandable. So we talk about this idea that information equity is the foundation of the navigation of everyday life, decision-making, and well-being. So in health, and public health communication, it's really critical, for society to be well informed and to maintain and sustain a healthy population. You kind of need a population that is well informed about disease, risk, prevention, and management. We saw all of that during the COVID issue, right? So one of the key things about the work on digital literacy is the assumption that it is really up to the patients and the consumers to understand what it is that they are doing, how they're accessing it, right? What I'm saying here is that it's not just about access, content, and literacy, but it's also understanding the demographics of the people who are going to be accessing this information and what their needs and what their expectations and what their values are in terms of how they use this. So when we are talking about co-creation and co-designing, it's really looking at asking the right questions. And this is why in the Melbourne Social Equity Institute, one of the things that came up a lot was the fact that we're not necessarily asking the right questions either. An example that I can share with all of you is that a number of years ago, I was doing a piece of work around international students and how they access information and where they were getting information from. And so the question that I asked these international students was obviously, you know, what social media platforms do you use? And there was a particular student who told me, you know, that they use Facebook, they use Instagram, that sort of stuff. And I looked at it, and it was a very short list. And I then asked the student, how long have you been here? And this was done in the US. And she said, I've only been here about 3 months. So I asked her the next question. I prompted her and said, what about the Chinese social media like WeChat, Weibo, all these others? And she looked at me and said, oh, you know about those social media platforms. She gave me a list of another 10 platforms that she used. So the questions that we ask and the assumptions that we make around what it is that we are trying to ask, and also what the target audience or the respondents are giving answers to, has a real impact on what we are actually emerging from the conversations that we have in our co-creation and co-design workshops. So the importance of information for personal and communal decision-making means that it's so important that we ask the right questions. So the Digital Access and Equity program at the Melbourne Social Equity Institute developed this digital design matrix. And I'm going to share, firstly, I'm going to share the principles behind it to look at how we look at this matrix, and then I'll try to go online to show you what the matrix looks like. Okay. Go. Okay, so when we are thinking about information for health equity, the questions that we have to look at are things like, what does the information we provide mean for diverse communities in context? This means that if we just look at the assumptions behind the information that we provide, we really need to think about whether the information means something completely different in a particular context, right? Even things like confidentiality, I always use that as an example. We talk about privacy and confidentiality. In particular cultures, privacy and confidentiality extends to the immediate family members, not just this individual or the patient at the core. And I think that's something that we always forget and I always get reminded when I'm doing work in this space. How is that information provided, and is it accessible and understandable for those communities? So again, back to the various platforms through which we are providing the information, or is it word of mouth that is absolutely more important, okay? And this is where when we talk about things like, you know, who has control over the information and who has control over the privacy of information and confidentiality, we also have to be aware that different cultures and different communities can view that quite differently. And as a result, decision-making can be viewed quite differently in health as well. When is the information provided is also quite important, because obviously there are cultural contexts that has to be taken into consideration. Who is it provided to? This is the example that I use around, for example, in the work that we do with bowel cancer. Are we targeting just the people above 50, or do we also have to talk to their adult children in some cultures who are part of the health decision-making process? So then are we ensuring that the adult children also have the right amount of information to support the decision-making process of their parents, rather than a fully person-centric or patient-centric approach of just leaving it to the parents? And that doesn't work as well in some cultures. Do the way that we do all of the things that above here present a clear bias in terms of, you know, this is our model of care, and so this is how it's done. But does that actually, going back to what Margaret was saying earlier on, are we actually in a model of care that actually factors in all the different cultural norms and values as well, as an example? So when we are looking at the digital equity metrics, we're really saying that, you know, we have to build in principles of privacy, the benefit, effectiveness, safety, equity, inclusivity, transparency, and accountability. So I can see some of the questions there around those issues. Absolutely, they're so important that we really have to think what are the principles around privacy, benefit, effectiveness, safety, equity, inclusivity, transparency, and accountability. And then those principles have to be applied to all the following processes, from planning to recruitment of people for co-design and collaboration, the data collection and analysis, the development and the operationalization of digital outputs or interventions, and the digital governance and maintenance. So across the entire design, planning, and implementation of digital interventions, we really have to ask the right questions, from privacy through to safety, equity, inclusivity, and accountability. So that's what the matrix, the way that we structure the matrix. And I'll show you the matrix at the end before the Q&A. So the example of this is that, you know, when we are communicating health information concerns, it concerns not just translation. So often when we look at projects, you know, the reason for why we brought this matrix on was so often in our the projects that we look at and the projects that we fund, they've done all the projects, and then at the end they go, oh, maybe we should put it online so that people can access it. And it's almost like we'll just do a translation into 50 different languages, it solves our information equity issues. No, it does not, because it's not just a translation of language, it's also needs to be done in the context of the culture. So for example, in cancer screening, we have to consider and understand the different social cultural health context. We have to understand the platforms that are being used. We have to modify information so that it's relevant to social cultural context in the way that we present it. And that evaluation needs to be inclusive and talk to a range of people. So you can see that it's a whole lot more than just translation, because the one size fits all, this is the information and we just have to translate it. And sometimes the translation is also not very good, can be a huge issue. So I try to cover quite a lot of things in 20 minutes so that we have time for some conversation. What I do want to do now is to stop sharing this for a second. Stop sharing this and go to the website, if you bear with me. Stop sharing. All right. So here we go. Share screen. So this is the Melbourne Social Equity Institute website, and under the Digital Access and Equity program, this is it's a PDF. Unfortunately, it's not very user-friendly, but we are in the process of fixing that. This tells you all the principles around why this design matrix is important, what are the principles, as I mentioned earlier on. And here are the questions that you ask across the different stages to be more inclusive and to ensure equity. So you can see, you know, it's too much for me to go through all of it, but I just wanted to share this with you so that you can have a look at it and ask questions that around benefit, around impacts, around sustainability, and around inclusivity as well, as we are designing and developing digital outputs and interventions. So I'm going to leave it at that. I'll stop sharing now. One of the lessons that we learned from this, I want to share with you is we are in the process of developing and translating this matrix into Bahasa Indonesia. And we are working with an NGO in Makassar, in Eastern Indonesia, and we are working with the disability disabled community. And the first thing they told us was this matrix doesn't work. And we were like, oh my gosh, what do you mean the matrix doesn't work? And the point that made to us was that for people who are communities who are disabled, or for the blind in particular, the layout of a matrix is very hard for any technology to interpret. So we have to convert the matrix into a checklist. That was our first thing. So as much as we try to do things, that's why we always have to check with different communities. The first thing we learned was matrix doesn't work, turn it into a checklist. So immediately we were learning things around this whole thing around inclusivity and equity. So continuously learning.
Thank you so much, Shanton. That was fabulous. And I love that story that you're telling at the end. And I think often we as academics, we love frameworks that,
yes,
put everything together in some way and it all makes sense about why and how. But that doesn't mean that that's what's really usable. I'm going to start with the question. I think it can be overwhelming because in my work, for example, I want to address all of those things. But there's so many different communities that might have different needs. How do you approach that?
I think
diversity, diverse communities.
Absolutely, you can't be looking at every single culture and community, and it's never about who you include. It's always about who you exclude. That's the challenge, right? And so I think that if you break it down and think about what are the communities that would have the biggest challenges in accessing. So the health data will tell us who is not accessing particular services. Why are they not engaging? From there, that's your first clue as to who you need to include. And I think that's really important. And then thinking about why is it that particular groups are not accessing services or using services helps us to then unpack, are there similarities across these groups, and start to ask those questions. And therefore you're narrowing down who you are actually including, because we all have limited resources. We can't be checking with everyone. But to continue to ask these questions, the challenge is when people ask their friends. And one of the things that I'm very conscious of is that, yes, we have access to cult communities, multicultural, multi-faith communities, but sometimes those people who are most active in those communities are also highly health literate and digitally literate, but you want to reach out to the community. So the most important thing is that it's not just the leaders, but also the wider community that's really important within those communities, if that makes sense.
Yeah, oh, I love that answer. And as we are building out using the learning health system framework to guide our work, the first step of a learning health system is using data to derive insights. And I think what we want to guide us is, how do you learn who's falling through the cracks, or where there's variation that's hurting, and which groups are suffering or needing more attention? Because like you said, we only have so many resources to put towards problems in healthcare. And what we want to do is target those resources to the people that need them most, rather than doing what Margaret showed, where just give everyone the same box, which is what we try to do now. So
yeah, and even the words that we use and the questions that we ask is so crucial. Like the one that I keep using is this idea of privacy and confidentiality. We are so it's so important, right, in the Australian health framework. And yet it means different things to different cultures. It means different things to people in different age groups. It means different things to people of different faiths. And so are we having the same conversation, or are we having parallel conversations when we are trying to design these digital interventions in health? Right, and the question that often arises here is, how do we engage with people with low health literacy? And the thing is, one of the key things here is that we have to work more actively with the NGOs and the not-for-profit sector and the people who are working and providing those allied health services, recognizing, of course, that they are very overworked, and really trying to engage through them to get to people in rural areas, to get to people with lower health literacy, and the people who potentially don't use digital interventions, because sometimes we're so focused on digital interventions. Here's me from computing and information systems saying, don't just rely on digital interventions, because at the end of the day, for some people, the face-to-face conversations through the NGOs are much more important. Yeah.
Thank you. I'm going to turn the time over to Mahima, who's going to be fielding questions from the Q&A.
Thanks, Wendy. It seems like a lot of the questions have been answered, but there's a few more that are coming up. I see a question by Gabriella. She's asking, how do you deal with privacy and confidentiality in collectivist societies and communities?
That is a fantastic question. How do I deal with that? I think one of the key things there is that consent is really important, and to explain that in particular communities where confidentiality and privacy, and that's why I keep talking about that as an example. You know, look, I'm going to use my own personal example, right? Anything that I in my health, my parents want to know, and there are things that I don't want to tell them, but they really want to know, and they'll nag me until I tell them. But by the same token, there is nothing private about their health as well, because they'll tell us everything, right? So, but it's about consent. It's about whether or not the patient is able to make decisions, or whether they want to involve somebody. The challenge is when the practice is so restrictive that we say, no, we can only tell the patient and no one else is allowed. So I think the change has to be around, of course, we will focus on just telling the patient and that's it. And confidentiality is very important. But the patient has to have the agency, and to be made aware of the agency if they want to involve someone else within the community or within their family, they are able to do that. And I think that's really important. And taking the time to check with them, rather than saying, we're going to close the door, we're just talking to the patient. And this can be an issue in elder communities, for example. And it's not just migrants, it's also indigenous communities. And I think that's where consent becomes really important.
Thanks. There's a question by DJ Adams. They are asking, how can consumer end users data sovereignty be assured across these platforms?
Yeah, I think this is where we need to have, when we look at the digital matrix, that digital and data management is a conversation from the planning through to the evaluation. That is not something that you slap on at the end and look for the cheapest digital solution that somebody has built off the back of their, garage because they are IT experts who is part of the team. So often a lot of these digital interventions and the security behind it is not thought through. This is why the digital matrix says from the planning, if you're intending to have a digital output or intervention, you need to start thinking about the data governance, all that sort of stuff, to make sure that all these things are thought through. So it's not something that you put on and you say you have 10K extra that you're going to get someone to design a website where people are going to submit some information. No. We can't do that. Often that's not considered. And given that the digital is such a huge part of so many health projects, it needs to be in partnership with the health intervention from the very beginning.
Thank you, Shanton. We have time for just one more question, and appreciate all the conversations happening on the thread. Unfortunately, we can't get to every single question, but I think this is a good one to wrap up with. Rinki is asking, would you recommend any particular validated tools for use in obtaining feedback about a digital health tool in called communities?
There aren't, because a lot of it is, if you're talking about, I don't know if you're talking about a particular tool in terms of a data collection, or are you talking about thinking through methodologies. I think that if we're looking at methodologies, we're really about having conversations, focus groups, and conversations with particular communities. If you're looking for a tool, various NGOs have particular approaches to these are the set of questions that we ask. The Center for Ethnic Health, for example, Ethnicity and Health, out in Richmond in Victoria, actually has a series of tools and frameworks that they use. Or you can use the Digital Access and Equity Matrix in terms of looking at the digital intervention. Those are the kind of areas that we encourage people to have those conversations with the community groups. I think I'll be out of time.
Yes.
I'll
Thank
try
you.
to answer the questions as we go along as well, because I'm watching the Q&A, so I hope that
Yeah, you
helps.
can go in and type your thoughts and we can continue that conversation. Thank you so much. And I really look forward to studying your matrix more.